Hello everyone. So today we will conclude our ECMO class, which is a part of ARDS lecture series. So in our concluding part today, we will discuss about the other different troubles that can arise in our ECMO patient and how to troubleshoot them. Right? So let us discuss. So the first trouble that can happen that you have to troubleshoot, that is chattering. So what is chattering? Chattering means visible shake or vibration within the cannula or tubing. So this is visible shake or vibration within the cannula or tubing, right? Why this happens? This may happen because of creation of high negative pressure, or you are creating the same negative pressure but now there is not enough blood or fluid to be taken, right? So that will cause the vessel to collapse near the rear end of the cannula, causing a vibration or chatter, right? So how to deal with it? This is very simple. If you have set the flow very high, we can decrease the flow by decreasing the revolution per minute. This will in turn create a less negative pressure and the shake or chatter or the vibration will reduce. However, in most of the situations, the problem is hypovolemia. So in this situation, you just have to replenish fluid. Give some fluid in bolus, or patient is hemoglobin is low, you can give PRBC, right? So if you replace the fluid, the hypovolemia will correct. Now the same negative pressure can withdraw the blood from the body, right? So that way you can deal with chattering. Second is oxygenator failure. So it can be two types. Number one is oxygen supply failure, and number two is oxygenator per se failure or the membrane failure, right? So you can see here, this is the oxygenator and it is receiving oxygen for the blender, and the blender receives oxygen from the wall mount. So this is the wall mount. Here we have oxygen source, we have air source. So from here they get the supply, and from the blender the oxygenator receives the oxygen and air, right? Now there can be supply failure here, there can be supply failure here, there can be some problem here. So we have to check whenever there is oxygen supply, we are suspecting there is oxygen supply failure. You have to check from the wall to the oxygenator if there is any problem in it, right? How to assess clinically if there is a oxygenator failure? So the blood that comes to the oxygenator is venous blood, so it will be dark red or blackish red. When it gets oxygenated, it will be bright red. So whenever this differentiation of color is not there, then you suspect that there is oxygenator failure, there is oxygen supply failure. So you have to check from the wall to the blender to the oxygenator, right? So the visual inspection is very important here. So you have to do visual inspection. Then you have to check the pathway. What is the pathway? Wall, air and oxygen, from there to blender, from there to oxygenator. This pathway is working or not, or if there is any problem in any place, right? Now what is membrane failure? Membrane failure is, so this is the membrane. Now the membrane has, it is a semi-permeable membrane. Through this membrane only the gas exchange will happen. If the pores of this membrane is blocked due to thrombus, then the membrane will fail. Then in that case there won't be also change in the color of the incoming blood and the outgoing blood. So there can be microthrombus which can clog the membrane, decreasing its efficiency. So how to diagnose it? We can see the drop in membrane pressure, right? A less than equal to 50 millimeter of mercury drop in pressure across membrane is expected. Right? If it is more than 100 millimeter of Hg, then you must be very suspicious. That is problem. The membrane integrity is lost. So you have to replace the membrane, right? So oxygenator failure is one of the most common complications that can happen. So when the blood comes into the oxygenator here and goes out, there is a significant pressure drop. That is called usual pressure drop, that is less than 50 millimeter mercury. So you can check the pressure here, you can check the pressure here. So the pressure here will be, the pressure drop here will be less than 50 millimeter mercury. If the pressure drop here is more than 100 millimeter of mercury, that means we have a problem in the oxygenator. So in that situation, we have to replace the oxygenator, right? Now coming to anticoagulation. The usual technique is we measure ACT, we keep it 1.5 to 2 times normal, that is around 105 to 180. In case where we cannot maintain this anticoagulation, then we can, what are the other method to decrease formation of clot? You can increase the flow. When you increase the flow, that decreases the stasis and decreases formation of clot, right? So when after maintaining a ACT of 180 also using maximum possible heparin, you are not possible to achieve anticoagulation. You can just increase the flow for some time and that will prevent stasis and that will prevent formation of clot. Now coming to hemolysis. How to diagnose? Hemolysis can be possible because of you are giving high flow or you are giving high RPM, because of small cannula size and wrong position. How to diagnose it? The diagnosis is increase LDH, increase in bili or increase in indirect bili. So solution is decrease flow, proper cannula and position, right? If there is bleeding, what to do? You can measure the ACT level. So the ACT level you have to maintain within a limit. Even after maintaining within a limit, if also there is bleeding, you can check what you call it APTT. It has to be kept 60 to 80, that is 1.5 times to 2.5 times of normal. We can also measure factor XL level, right? We can also measure via what you call as the most informative TEG, thromboelastography, right? This can also help to find out what is the cause of our bleeding and take corrective measures, right? So there is another thing happens here, that is called the heparin resistance. So if there is increase in requirement of heparin, so we will write it here. So if there is significant increase in requirement of heparin to maintain ACT. So in the beginning we were requiring a small amount of heparin to maintain the activated clotting time within the range that we prefer. But now the requirement is increased. So that means we have to suspect here patient can have heparin resistance. In this situation, you have to measure antithrombin 3. If it is less than 80% of normal, then it is deficient. In that situation, we have to give FFP, right? Now coming to heat and DIC. Heparin-induced thrombocytopenia, as the name suggests, there will be decrease in platelet within 5 to 10 days of starting heparin. There is formation of thrombus. Right? If this happens, then you can check the heat panel, heat antibody panel. If it is positive, then you have to replace heparin with change heparin to either bivalirudin or argatroban, right? Of course, there can be DIC. DIC can have two reasons. One is sepsis can cause DIC. Another is microthrombus in the circuit that can initiate a DIC, right? So it has to be dealt with accordingly. If there is microthrombus in the circuit, it has to be changed, or sepsis has to be dealt separately, right? Also in DIC, you have to replace factors. Now coming to sepsis. Sepsis in ECMO patient, CRBSI or bloodstream infection, and what are most common? Temperature may not be high because in ECMO temperature is regulated. We have a warmer outside, so temperature is regulated, so patient may not have a fever, but we have to rely on the soft signs of sepsis. What are the soft signs of sepsis? So you have to see if there is an increase in TLC, increase in vasopressor requirement, or there is increase in lactate, right? Or there is increase in FiO2 requirement, or there is new patch in chest X-ray. Right? So these are the things that you have to see in your patient, whether the patient developing any signs of sepsis or not, and accordingly we have to treat it, right? So periodic surveillance, culture, procal and empiric, broad antibiotics, right? The problem with sepsis is, if sepsis will be there, the cardiac output will increase. So the ECMO blood flow by cardiac output, this will decrease less than 60%. It will produce what you call as circuit shunt, and there will be hypoxemia, right? So we have to treat sepsis as fast as possible and have to decrease the cardiac output. How to decrease the cardiac output? We can use antipyretics if there is fever, which is unlikely. You can use esmolol to decrease the heart rate. You can also induce hypothermia. Of course, you have to treat sepsis, right? What are the catastrophes that can happen in ECMO patient and how to deal with it? Patient can have air embolism because you are dealing with cannulas, big cannulas that can happen. Air can embolize. In that situation, what you have to do? You have to stop the ECMO and clamp the cannula near to its origin, so that you do not give further air to the patient, and then the treatment of air embolism are supportive that we do usually in our patient, we will do it. But the important thing is you have to clamp the cannula near to its origin. So you can have a pump failure. So always keep a backup pump, right, ready. Otherwise you can use the hand crank that is given along with it, right, to manually pumps for some times. Third, if there is cardiac arrest, what to do? Since it is a veno-venous ECMO, we are not providing any support to the heart, so all the ACLS algorithm will apply here. CPR, cardioversion, okay, will apply. All the SLS algorithm will apply. Plus, if the cause of cardiac arrest is cardiogenic, we may have to revert the veno-venous to veno-arterial or veno-arterial venous ECMO, right? Because here you also need a support for the heart. So these are the things that can happen to our patient and how to deal with it. With this, we conclude our lecture on ECMO. Thank you very much.